and please take a look at all the different features on the app. What I'm going to do now is, let's see, is Dr. Guy, yeah, there we go. She's going to share her screen in a minute. So I'm going to introduce Dr. Jennifer Guy. Dr. Guy originated from the Northern Plains and first looked east from her education, where she completed her undergraduate training at Dartmouth. But she also wisely came back west, where she did medical school residency, GI fellowship, additional training in clinical research at UCSF, and then spent 2 years as an adjunct assistant professor of medicine there. We at CPMC were very fortunate to lure her over to direct our liver cancer clinic 10 years ago, and it was 10 years ago this year. Dr. Guy was a co-author on the 2020 ASCO guidelines for systemic therapy for HCC, so that really speaks to her expertise in HCC, but she maintains a very busy general hepatology practice, and I've heard her speak on liver disease in pregnancy, fatty liver disease, viral hepatitis, and so she gives a fantastic talk on benign liver lesions, and I think her background expertise in HCC gives her that much better perspective. I think she's very well suited for this group, and thank you, Jennifer, for this talk.
Thank you. I'm going to try to share my screen here. Let's see. Okay, can you see my screen and the slides?
You bet, and hear you still.
We've been into 10 months of Zoom and I'm still always like, can you see my slides? Well, thank you everyone for joining, and please stand up and get a stretch break as we enter our final speaker today. But thank you to Will and colleagues for inviting me to speak today. And I'm going to talk about benign solid liver lesions. And our learning objectives today are to review the differential diagnosis for benign liver lesions, outline the radiographic and clinical features for benign solid liver lesions, and discuss management strategies for these liver lesions. And this is just a typical month of liver clinic, and Dr. Mehta and I are both very glad when we see that there are many non-cancerous liver lesions on our clinic schedule, because we all have to remember that thankfully not every liver lesion is cancer. But these different patients remind us that the clinical history is very important in trying to ascertain if someone has underlying liver disease, because that helps us to get a sense of the pretest probability around whether or not we're thinking more on the malignant scope or on the benign liver lesion scope. And oftentimes people are coming to liver lesion clinic with an ultrasound or a CT scan, and you're wondering if what is the next best diagnostic modality to help get a better sense of what the liver lesion is. So this is a differential for benign liver lesions, and we're going to talk today about solid liver lesions in the 25 minutes we have. But just remember that there is a whole other side of things, which is the cystic liver lesions. And the most common cystic liver lesions are hepatic cysts, mostly simple cysts, hepatic abscesses. Echinococcus is something we don't want to miss in terms of how we're going to manage that. And then mucinous cystic neoplasm, which used to be called cystic adenoma. And then when there is invasive cancer, that's mucinous cystic neoplasm with invasion, or the prior cystic adenocarcinoma. So I'm not going to speak about cystic lesions today and really focus on the most common solid liver lesions. And these are arterial enhancing lesions on cross-sectional imaging, hemangioma, focal nodular hyperplasia, adenoma, and focal fatty lesions we're also going to talk about. A lot of the data today is from the EASL guideline, and so I put it here as a reference if people want to read it. It's a good review. So we're going to do cases just like what Dr. Mehta did. So the first case is a 58-year-old gentleman with hyperlipidemia and a BMI of 30. He had a 4-centimeter hyperechoic lesion on ultrasound. And then this was followed up with an MRI, as you can see here. It's arterially enhancing. And then as you go through subsequent phases, you can see that there's central fill-in to the final panel on the right. I don't have a panel for T2, but you would see that it was T2 hyperintense. And so the diagnosis of this, and I'll pause so you can say it in your head, is hepatic hemangioma. Hepatic hemangiomas are the most common solid liver lesion, present in about 0.4 to 20% of the population, depending if you're looking at cross-sectional cohort or autopsy studies. And the pathophysiology is it's a non-epithelial lesion with microscopic cavernous vascular spaces that results in the arterial enhancement with the venous fill-in. On ultrasound, they're usually hyperechoic, and in fact, in some guidelines, they will say that if you have a single lesion less than 3 centimeters that's hyperechoic, you can use that alone to diagnose a hemangioma. Though the best diagnostic test truly is the MRI with a sensitivity and specificity over 90%. And radiographically, I showed you what that looks like with the peripheral enhancement with fill-in. But oftentimes in our tumor board, we also get atypical hemangiomas where maybe it's a sclerosing hemangioma, or maybe there's actually some capsular retraction on top of it. Or sometimes there can just be calcification in larger hemangiomas, or even some more heterogeneous to suggest potentially some bleeding. And so the diagnosis can be a little bit unclear from a radiographic perspective, and MRI oftentimes can help us with that if you see a non-diagnostic lesion, for example, on CT scan. The lesions that are less than 2 centimeters can also have variable filling patterns. So you may have seen the flash filling hemangioma as an example. You can continue birth control and get pregnant because these lesions are not hormonally responsive. And I think we're going to go through all these lesions and remind us of which ones are, because this does get confusing for people. Importantly, hemangiomas do not rupture, nor do they cause malignant transformation. So for that reason, once you are sure that you have a radiographically classical hemangioma, you do not require ongoing surveillance, and surgical intervention is rarely required. Though there is always a caveat, and so the caveat is a giant hepatic hemangioma, which there's a picture here. And you can see that there's just a large lesion with, in fact, some hemorrhage down here at the bottom. It's compressing the stomach and the porta hepatis. So this patient was having symptoms, and so the surgeons are going through an evaluation right now to determine how best to surgically resect this patient given symptoms and compression of nearby structures. Giant hemangiomas are defined as over 10 centimeters, and some rarely can have an inflammatory syndrome where they have thrombocytopenia, coagulopathy, and purpura, and that's called Kasabek-Merrick syndrome. And that would be another indication for resection if you saw that with a giant hemangioma. Oftentimes we get referrals for hemangioma that's grown, and people are like, well, do we need to be worried about that fact? And so this is one study, and these studies are really challenging because oftentimes we're not following hemangiomas purely because we say it's hemangioma and then we stop following. But this is an analysis of 160 patients from Wisconsin back in 1997 for a decade, and they looked at patients, median age was 50, 3-to-1 female predominance, size was 3 centimeters. And just to note that if you read the guidelines and studies, this is the classical description that people present between their 30s and 50s. They're women, and oftentimes the median size is 3 centimeters. And of the lesions they looked at, 40% of them grew by 5% in size, as they determined to be 0.3 millimeters per year, 0.3 millimeters, so small measurements here. 45 grew over 5%, which they marked as 2 millimeters per year. And those lesions that were over 5 centimeters were more likely to grow. And I don't quote these numbers to my patients, but what I say to them is hemangiomas indeed can grow over the long time that you have them. And therefore, if you get serial imaging because you happen to go to the emergency room with abdominal pain and get an ultrasound, don't be surprised if the lesion is larger. But let's just make sure we're talking about the same lesion and it has radiographic characteristics of hemangioma, and you don't have a new lesion that has developed and people are talking about apples and oranges. So indeed, these lesions can grow, but if they're small to begin with, they're unlikely to cause symptoms. And we can all remember that liver lesions of less than 5 centimeters typically do not cause symptoms. And even many who have lesions over 5 centimeters do not have symptoms. So I see hemangioma as a very reassuring diagnosis, and we can discharge them from our liver clinic. This is the second case. This is a 32-year-old woman who came to see me with a 6 centimeter right-sided lesion. It was found incidentally when she was undergoing pelvic ultrasound. And so this was followed up with an MRI, as I'm showing you here. And what you can see is an arterial enhancing lesion, which is homogeneous and a little lobular around the edges. And then as you move into the portal venous and hepatobiliary phase, you see it becomes isointense. And then on the hepatobiliary phase, and this is with hepatobiliary contrast, eovist, you can see that there is uptake of the lesion, uptake of the contrast, and you can see the lesion as bright. So I will pause for a moment so you can say the answer in your head. You're right, it's a focal nodular hyperplasia. So the focal nodular hyperplasia is the second most common liver lesion, present in about 0.4 to 3% of the population, also with a female predominance, which is more on the order of 9 to 1. And the pathophysiology here is that you have an abnormal artery where normal liver cells have a regenerative response and grow around it. There's disordered hepatocytes around an abnormal blood vessel. These can be seen in 20 to 30% of the time as multiple lesions. And on ultrasound, in contrast to hemangioma, they're rarely hyperechoic. And in fact, they can be isoechoic and not be seen on ultrasound. The diagnostic modality of choice here is the MRI with eovist, again, sensitivity and specificity around 90%. And as I showed you in that picture, it's very specific for the FNH to hold on to the eovist. And also you can see a central T2 hyperintense scar, which is actually that abnormal blood vessel. There is a caveat here, which is important, and that is inflammatory adenomas that I'm going to talk about. They actually do retain bile ducts, and therefore they can also retain eovist. This is rare, maybe up to 10% of the time, but it is something to think about when you're looking at the clinical picture, and if there's any concern that you might be dealing with something other than an FNH, if you need to go forward with biopsy as a result. Again, reassuringly with focal nodular hyperplasia, rupture is rare, there is no malignant transformation, and these are not hormone responsive, and therefore you can continue birth control. Biopsy, as I mentioned, is required in the situation where you have an indeterminate lesion, maybe it doesn't take up eovist, but you're still wondering if it's FNH because maybe there's a hint of a central scar, or it's homogeneously enhancing, and you're not sure if it could be an FNH or adenoma, and that's where a biopsy may indeed be helpful. Because again, if it's an FNH, we can say this is what this diagnosis is. You don't have to worry about this any longer. On histology, there is a map-like staining pattern for glutamine synthase. And this is different than a glutamine synthase stain that we use for adenoma, which I'll talk about in a bit. And once the diagnosis is established, because they don't rupture and because they don't have malignant transformation, FNHs also do not need to be followed further. Surgical removal, therefore, is rarely indicated. And we've had cases where we had like a non-diagnostic biopsy, non-diagnostic imaging, lesion over 5 centimeters resected. Or I've had patients where they're young, they want to get pregnant, they don't want to wait for another serial scan because it's the first scan, they didn't want to biopsy, and they just say, take me to resection. That's pretty unusual. These are rare instances. And finally, sometimes patients have such severe abdominal pain that they want their lesion out. So also focal nodular hyperplasia can grow, and this is a flawed study, but a study nonetheless, looking at ultrasound every 6 to 12 months in 34 patients with biopsy-proven FNHs. 70% of them remained stable, 3% progressed, and 26 regressed. Though it's possible that some of these, though they were biopsy-proven FNHs, were indeed possibly inflammatory adenomas, which used to be called Hepatic Adenomas. So I think here again, I'm not quoting these numbers, but I recognize that indeed the focal nodular hyperplasias can grow, and I've seen some regress as well. So next case is a 32-year-old woman who had a 6.5 centimeter right-sided arterial enhancing lesion. She presented with mild abdominal pain and bloating, underwent an ultrasound, followed up here by this MRI, and she's interested in getting pregnant. So we're now trying to figure out what do we do with a 6.5 centimeter lesion. She's not on birth control. She's actively trying to get pregnant. And on this MRI, you can see, again, arterial enhancing lesion. Maybe I could convince you that there's a little bit more heterogeneity in terms of the enhancement pattern. Here even you can wonder if you're like, oh, I wonder, could that possibly be even some washout? And then here on the eavist phase, there is no retention. It's dark rather than bright like the prior MRI had showed you. And the answer here is a hepatic adenoma. You can now tell that I'm running down my list of differentials, so there's no surprises here. The hepatic adenoma is the third most common and therefore less common than FNHs by on an order of about 10 times. Again, female predominance, 10 to 1. And the pathophysiology here is these are clonal hepatocytes that have proliferated. So they're not malignant, they're clonal, they have not taken on malignant mutations. And on cross-sectional imaging, there's arterial enhancement. They can have intralesional fat. They can have washout, as I sort of hinted to on the MRI. And MRI is the modality of choice in these lesions because I'll show you in a subsequent slide, there are some specific T1 and T2 and fat saturated patterns that the radiologist can look at. These are pretty subtle. And so it's important to remember that if you are seeing a patient who has a liver lesion, you're wondering what it is, your radiologists are calling it indeterminate. That's one of the reasons why we have liver lesion clinics at Stanford, UCSF, and CPMC, is so that we can provide our multidisciplinary review with our expert radiologist to get a better sense to make sure we have the diagnosis correct. So hepatic adenoma, strong association with oral contraceptive pills, 30 to 40 fold increase. And therefore, the management obviously is to stop birth control pills. They're also associated with anabolic steroids, so those need to be stopped. And they're also associated with obesity, a specific subclass called the inflammatory adenoma. So weight loss is encouraged. These lesions often will regress when you remove birth control. It can take 6 to 12 months to see that they are regressing. Sometimes they regress completely. Other times they shrink to being less than, for example, the 5 centimeter cutoff we're worried about. So this is very important to think about. They can grow in pregnancy, and the EASL guidelines recommend actually monitoring with ultrasound every 6 to 12 weeks during pregnancy. Depending on what size it is, determines how I'm going to be monitoring it over time. If I'm seeing a patient before pregnancy who has a lesion over 5 centimeters, we're having a real discussion about what we're going to do about it if we need to resect it beforehand. The adenomas, in my mind, are a different class of lesions as compared to the FNHs and hemangiomas. And that's because, indeed, there are risks to these lesions. There's a 25% risk of rupture when lesions are over 5 centimeters. And there's about a 5% risk of malignant transformation. And we're going to talk about how the adenoma molecular subclasses kind of help us think about that further. I just show one study here of 165 resected adenomas, and they showed a foci of cancer in about 9% of them. These were lesions that were over 5 centimeters. And so there was some selection bias here. But if you look at the various guidelines and papers written about adenomas, the risk of malignant transformation is quoted as anywhere to 6 to 10%. Surgery is recommended, therefore, for lesions over 5 centimeters, given this risk of rupture, given the risk of malignant transformation. Any beta-catenin lesion, which I'm about to outline, regardless of size, is recommended to be removed. Any lesion in a man, because the risk of malignant transformation is much higher for men, maybe all the way up to 40%. And if a woman is planning to get pregnant, has stopped her birth control, has not had regression of her lesion, and it's over 5 centimeters, we have a serious discussion about resection prior to proceeding. If we're not going to be moving forward with a resection, the recommendation is to monitor every 6 months until stable for a period of 12 months based on EASL guidelines and 24 months based on ACG guidelines, and then thereafter yearly imaging. What I do is if we've diagnosed an adenoma and we're going to be monitoring it, depending on how big it is, and if I'm worried about it, if it's a 7 centimeter and she's stopping her birth control, I might get one at 3 months just to ensure that we're not going bigger instead of smaller. But typically I'm doing at diagnosis 6 months, another 6 months to span that year, and then going to yearly MRIs. So what about molecular subclassification of adenoma? Can we use a biopsy to stratify for the outcome of the patient? So I'm going to review the molecular stratification. This is really quite amazing work done by a group in France. Jessica Zuckman-Rossi has really pioneered all of this. And they break the adenomas up on their molecular classification into, I'm going to talk about the three main groups. The first is the HNF1 alpha, which is the hepatic nuclear factor 1 alpha inactivation. That's the pathway that's inactivated. And these show by histology fat. So if you're seeing those adenomas and they're full of fat, that's these adenomas, and they're approximately 30% of all adenomas. And you can test them in terms of trying to determine what they are by doing a stain histologically for a fatty acid binding protein, and that expression will be decreased. And so that's one way, along with histology, to diagnose an HNF1 alpha adenoma. And these are important because actually looking at more and more of the data that's coming out, there is not a risk of malignant transformation for these lesions less than 5 centimeters. And many times we're leaving lesions less than 5 centimeters, in the patient unless they're beta-catenin positive. But this really does, I think, provide some reassurance to patients. And I'll show you that there are also some special radiographic characteristics that may allow people to diagnose these without biopsy. But that's really in specialized centers. The next type of adenoma, another 30% of the adenomas, is the inflammatory adenoma. And this is an activation of the JAK-STAT pathway. And so there's overexpression of SSA when you actually stain the lesions, and the lesions have a lot of inflammation in them. So you see a lot of mixed infiltrates. And so these lesions, indeed, they have rupture risk, but they also have a propensity to actually also potentially stain for beta-catenin. About 6% of them will stain for beta-catenin. So it's just important to make sure that if you see the inflammatory histology, that the pathologists are still staining for the beta-catenin, because there is a small risk for these lesions to have that. The final one I'm going to talk about is the beta-catenin mutation pathway adenomas, and this accounts for about 7 to 10% of the adenomas. And these are important because these have higher risk of malignant transformation, and therefore they require resection at any size. And what you can do to diagnose these is to, you can look for nuclear beta-catenin, but that's not a very sensitive stain, but you can look for increased glutamine synthase expression. And if you see that, then you have your diagnosis of beta-catenin activation. This is different than glutamine synthase map-like staining for F and H, so it's just something to be aware of. The other types of mutations, the beta-catenin in a different exon, we're talking about exon 3 right now, but there are beta-catenin mutations in exon 7 and 8. These do not carry the same malignant transformation risk. There's something called a sonic hedgehog adenoma, which is less than 4%. They have an increased risk of hemorrhage. And then there's some unclassified. But really, our pathologists were really looking for those three main most common adenomas to help us determine if we can think about them and incorporate them in our decision making. So as I reviewed already, the management for adenoma is surgery for those lesions that are over 5 centimeters and have not regressed with weight loss or stopping birth control. Any beta-catenin positive lesion, any lesion in a man, as I alluded to, and then if they're planning to get pregnant. For a ruptured hepatic adenoma, bland embolization to stop bleeding and to control the hemorrhagic shock is important. And then after that, there's always a bit of a nuanced discussion about, do we resect? Do we, wait and see what happens with the adenoma? And then once the subcapsular hematoma gets better and the lesion actually could have possibly shrink and go away if they stop the birth control and they've been embolized. So there's a bit more nuance there. And if we're not going to be doing surgery, I already mentioned the monitoring that we follow. So hepatic adenomatosis is where you have multiple lesions, 3 to 10 or more lesions. And these can be seen with with glycogen storage disease. And in patients who have hepatic adenomatosis, it's a rare indication for liver transplant. And it meets criteria if there becomes malignant transformation by biopsy, but because there are so many lesions that you can't resect, then that would be a consideration for liver transplant. Also, the presence, as I mentioned, of glycogen storage disease increases the risk of malignant transformation. So that's another thing to be considering in these patients when petitioning for liver transplant. I'll say in the 10 years I've been at CPMC now, we've done one patient with hepatic adenomatosis in that decade. So this is my final case. This is a 55-year-old woman with diabetes, elevated AST and ALT, who had an ultrasound as a workup of that and has this 2-centimeter lesion on ultrasound. By MRI, it shows an arterial enhancing lesion. I gave you the hint of the pink arrow because it's quite hard to see, persists into the delayed phase and in segment 4 right by the gallbladder fossa. And so this is a focal fatty lesion. So this is focal fatty sparing. And when we see this, we can say, okay, there's not a lesion ultrasound, it's not borne out on an MRI, and we manage the fatty liver disease and the metabolic syndrome. So this is a chart that I wanted to just share for those of you who are really interested in the subtleties of MRI diagnosis of adenoma. This is from the ACG clinical guideline. And what it's just pointing out, the first one, for example, is this HNF1 alpha adenoma. And because there's a lot of fat in it, there are some changes by MRI, T1, T2, fat suppression images that in the experienced eye, you could say, oh, this is an adenoma and it's an HNF1 alpha, and therefore we've got that diagnosis. I think that's pretty uncommon that we are doing that. The THCA is actually the inflammatory adenoma. This is in 2014 when it was written, that was not actually coined, the term coined yet. And the THCA, there's a real strong arterial enhancement, and actually in some later phases, you can get kind of a circular arterial enhancement. It's called the atoll sign, like the atoll island. So that's why MRI ultimately is where we go to, because it gives us these other phases that can really help us try to distinguish between the black box of an arterial enhancing lesion. And then remembering that Eovist, this hepatobiliary contrast agent, is very helpful for the FNHs. So take-home points are that the clinical history is really important in assessing for underlying liver disease to determine what the etiology of the liver lesion may be, as benign or malignant. The radiographic characteristics, as we've outlined by ultrasound and MRI, can be very helpful. And then liver biopsy, if we're wondering what to do about an indeterminate lesion, or if we want to subclassify an adenoma. Adenomas over 5 centimeters, any beta-catenin positive lesion, or an adenoma in a man should be considered for resection. So there we go. I'm happy to take some questions.
Jennifer, thank you very much. I'm going to read the questions that we have so that everyone can hear them. But before I do that, as promised, I want to make sure that I reveal the winner of tonight's game, which is who is going to receive a $100 gift card. A big thank you to Mike Way for your participation and your efforts. Danny will get in touch with you soon. So Jennifer, there are a couple questions, and if there's time, I have one as well. Going back to when you were talking about adenoma versus FNA, or FNH, excuse me. The question was, is Eovist available? And I think to expound on that a little bit, maybe the way I'll pose that question to you is, have you been in communication with centers where it's not, and how has that changed the situation for you and for the referring provider?
That's a great question. So there are indeed some radiology institutions where we've tried to send our patients because we get a large referral from Northern California, and we haven't been able to get Eovist. That is actually pretty rare. And if that happens, I send them to a place as close as possible that does have Eovist, because it really helps us to figure out if we can avoid a biopsy. If a patient has a lesion, we get an MRI with Eovist, it retains Eovist, then we're done. We have a FNH and we can kind of just stop it. We don't have to follow with imaging. Otherwise, if it remains an indeterminate lesion, we feel like it's likely benign, it's small, we can monitor it. We're still having to monitor it. And that's, you know, it's a it's a hard thing for patients to sit in the MRI. Sometimes they need Ativan every year. So it's just, if we can get a diagnosis, I think it really behooves us to, and therefore finding a place that does EOVIS is a good idea.
Okay, great. The next question, in your experience, are these all incidentally found? I guess that's versus another source of diagnosis, including symptoms, I suppose.
Right. I mean, I think we get a lot of incidentally found lesions because someone goes to the emergency room with abdominal pain. And then now they have a lesion and they're told to follow up. And so we do see a large amount of those patients, but at the same time also we're getting the patients who have abdominal pain. And what I tell my patients is, you know, when you start asking about abdominal pain, we're all gastroenterologists, like it could be so many different things. And but people will fixate on the fact that, oh, I have abdominal pain, I have a liver lesion, there's my answer. And oftentimes I walk patients through the idea that, you know, and people come and they just say, take it out because I want this pain to go away. And I go through the exercise of saying, even if we take out your lesion that's over 5 centimeters, so indeed possibly causing pain, 50% of the time the pain does not go away. And we have been in many of these situations where we remove adenoma because we needed to, yet the patient still has their pain. So their pain wasn't coming from the adenoma. And I think that's an important lesson for all of us to remember.
Next question is, with FNH, is there a size greater than 5 centimeters, for example, or larger, where you would worry about rupture, and would that affect your management?
No, FNHs do not rupture. They do not have malignant transformation. So you don't have to worry about a large lesion having those outcomes. The thing we do wonder about is, could that FNH that's 10 centimeters, for example, cause abdominal pain? And would that be the indication for resection? So I've had patients who have had 12 centimeter FNHs and they had pain, and we resected, and it was the right thing to do because the pain went away. But it's a real discussion about, you know, liver surgery is a very technical surgery with potential complications. And so if patients can live with their pain, then often they will. And I've had patients say, oh, like when I'm doing an exercise, I'll feel the lesion. So then I just remember that I shouldn't stay in that position, and then it goes away and they're like, I don't want surgery. So we're never worried about the rupture or malignant transformation with FNH. And that's why once we make a diagnosis, we don't have to continue to follow. The other thing that I would say is that some people feel very anxious about knowing even that they have a hemangioma or an FNH, i.e. these things are unlikely to cause you problem, but they still want to know if it's growing over time. And so sometimes what happens is we undergo this process where we do a few scans every year just so that they start to understand sort of that their lesions are stable or they're growing, but just a little bit, and then they're able to let it go and not follow. But we do not have to follow those lesions.
A question now asking about surveillance of all of the lesions you talked about in pregnancy. Which ones should be and which ones do you survey?
The ones that I survey are adenomas, based on those guidelines every 6 to 12 weeks, based on size and a little bit more around how the patient feels about, you know, what's going on. If it's a 2 centimeter lesion, I'll check it at 12 weeks. If it's 3.5, I may be checking it, you know, sooner than that. And I try to actually avoid doing any kind of ultrasounds during the first trimester and wait and look in the second trimester and then the third trimester as an example. FNHs do not require surveillance during pregnancy. Hemangiomas do not require surveillance during pregnancy. And I had a patient who had a 7 centimeter left-sided FNH. And she got pregnant and she could feel it because with the uterus pushing up on her liver, she could actually feel it, and she was actually having some impingement on her stomach. And, you know, we worked through it, but we weren't worried that it was going to rupture. We weren't worried that, because we knew it was an FNH because we had biopsied it before her pregnancy. So I think that, you know, they can have some symptoms because of the change in their physiology, but we shouldn't be as worried about those as long as we know the diagnosis.
And then I'd like to piggyback onto that question with the opposite end of the spectrum, which is, and I haven't seen the situation, but what would be the treatment if you had, say, a woman who entered pregnancy with a borderline adenoma, maybe 3 or 4 centimeters, you checked halfway through pregnancy and it was 7 or 8 or more. That may be far-fetched, but what I'm asking is, what if you really get to that situation where you're like, this is why I'm checking?
Yeah, well, we do have a case like that in the past decade. And so the options are embolization. So embolization could be done to decrease the risk of growth and bleeding, right? Or resection. And resection, if that's going to be undertaken, best, early in the 2nd trimester. And so those I've known about both of those having happened in pregnancy. There's some data regarding in patients who have adenomas and are not resectable, what is the role of embolization? And I did find a study that was done in Amsterdam, and it looked, I think maybe around 50 patients. And what it showed is that 10% of patients had some serious complications from that, abscesses, pain, but all those lesions did shrink, and the median size was over 5.5, and they shrank down to about 3.2 centimeters. So I think embolization would probably be something we would try to discuss, because that seems the safest for the fetus, given that, again, hepatic surgery, it can be a big deal.
Yeah. And we are reaching the end of the questions, but I have one more. So one of the things that stood out to me about the table that you showed, the biomarker table or the stains table, was that there are now at least one subtype of adenoma that, if you can be certain, doesn't transform, doesn't have malignant transformation. So my question is, are you using biopsy differently than you did, say, a few years ago? Are you using biopsy now ever to rule out the need for surgery, whereas I might imagine you might have needed to use it to rule in the past? Or how are you using biopsy in adenoma?
Well, this is an area of active investigation. This has not made it into, expert opinion about whether or not it should be used to actually determine clinical management. Right now, it's trying to get more data to ensure that biopsying and then making a decision and following is the right thing. And the HNF1 alpha, no risk of malignant transformation in lesions less than 5 centimeters. And so in a lesion less than 5 centimeters anyway, you probably weren't going to resect it. And, so I think it still doesn't quite help us to rule out surgery. It might make us all feel a little bit better if it were a 7 centimeter, for example, HNF alpha 1. We might say, well, we think that the risk of malignant transformation is probably less than 6%. And if it's a technically difficult surgery, I think that's the other thing that really weighs in here is, where is the lesion located? Is it technically difficult? How is it related to the hepatic veins and other vasculature for us to see? Is it going to be a big resection? Because if it's going to be a big resection, we really think a lot harder about, can we leave the lesion as it is?
Well, that's very helpful. That was our last question. So Dr. Guy, thank you very much. That was a very informative, great summary. I learned a lot. And then to all of our attendees, I'll just say a final word. Thank you all for attending. This was the 3rd of 4, so there's one more, virtual liver symposium of the NCSCG. And so hopefully you'll be excited about coming next week as well. And then one final thank you to Radhika, Marina, and Bilal, my co-planners, and to Liat tonight, my co-moderator. And then especially to Danny Smith and the rest of the PACE medical staff who really put this on for us. Thank them whenever you get the opportunity, and I hope you all have a great night.